Thank you very much, Bradley. Welcome everyone to this session on inclusion, health and LGBTQ plus communities. My name is Monika Rozansky. I'm the service lead for inclusion, health in public health at Birmingham City Council. And I'm joined today by Professor Caroline Bradbury-Jones from University of Birmingham, who is the project lead for the sex worker needs analysis for Birmingham. And just a reminder, some of you may have already attended previous sessions. We are going to be guided by principles of the safe place approach to our webinar and conversations. So just I'll leave you for a moment to briefly read this, the information on the slide. But in a nutshell, we're going to have respectful conversations, we'll be guided by empathy, care, support, and of course, inclusion. So what can we expect from today's webinar? We aim for the session to be quite interactive. We'll share some context, facts, evidence, and also mention some of the initiatives or programs that are linked to LGBTQ plus health and inclusion health. And we hope it will provoke further thoughts and open an insightful discussion from which we all can learn and take something away. And to share your comments, knowledge, experience, or participate in a discussion throughout our presentations and this webinar, please use the chat function or simply raise your hand, and one of the public health team, either Bradley or his colleague, will be able to relay what's in the chat, or will notify me when you've got your hand raised so that we can bring you into the conversation. This is because when I'm presenting, unfortunately, I cannot see those functions via Teams, so apologies for that. So I'd like to kick us off with a little bit of a thought about what inclusion health is. So if you'd like to either drop something in the chat, or if you'd like to raise your hand and talk about this, please come forward now. It's just trying to test what your understanding of inclusion health may be, and there's no right or wrong answers. So it's not to test your knowledge, this is to just test whether the understanding of inclusion and inclusion health is what that understanding is in the room. Are there any hands up or anything in the chat, Bradley?
Not yet.
The clue is on the slide. However, I understand it's the afternoon and it's Monday. So if you want me to carry on, I can share with you the sort of official definitions of inclusion health. Happy to do that, unless there is anything appearing in the chat or there are any hands raised now.
Somebody's typing, Monica, I can see that.
Okay. So let's give it a moment.
Okay, so in the chat, Hannah has put people in socially excluded groups that have different high healthcare needs.
Yes, that's great. Thank you very much. Any other thoughts or definitions? Well, I'm going to move us on, but please do share your thoughts and what you think we should be using as a definition for inclusion health, obviously in relation to health. The official definitions are here. So the one that is most commonly used in the healthcare and care world is the one by NHS England, which basically, what Hannah has put in the chat, refers to the different population groups within the inclusion health sort of umbrella. And those are people who are traditionally socially excluded, who typically experience multiple interacting risk factors for poor health, such as stigma, discrimination, poverty, violence, and complex trauma. But there is another definition that I have found, which actually talks about inclusion health as a field or as an area that seeks to prevent and address health inequalities experienced by those socially excluded or traditionally excluded or marginalized groups that are living with those extremely poor health as a result of multiple factors. And people in inclusion health groups typically include people who experience homelessness, people with drug and alcohol dependence, vulnerable migrants and refugees, Gypsy, Roma and traveller communities, people in contact with the justice system, victims of modern slavery, victims of domestic abuse, sex workers, as well as other marginalised groups. And the interesting fact is, and incredibly important when it comes to actually looking at health and well-being of the LGBTIQ plus communities, is that the World Health Organization refers to these communities globally as an inclusion health group, because they are less likely to access health services due to stigma and discrimination, as well as persecution that they may experience in many countries, experiencing human rights violations, including violence, torture, and criminalization, and are experiencing significant physical and mental health inequalities, often from overlapping increased risk factors for ill health. And that is actually the fact across the globe in all countries. So another question, and I'm sorry if you weren't quite prepared to be asked to kind of participate, but if you have any thoughts and knowledge about the existing health inequalities or inclusion health needs affecting LGBTQ plus populations, please drop something in the chat or raise your hand to share your knowledge or share your experience. And just a reminder what health inequalities are on the screen: the unjust and avoidable differences in people's health across different population groups. So I will open the floor to any comments, thoughts, or the chat function for your contributions, please, before I give you an overview of some of the inclusion health needs.
Awesome. So we've got one that's coming already from Osh. So GPs generally not being aware of trans plus people's healthcare needs.
Yes, that is certainly a clear gap, and that's not actually across the healthcare, but various other sectors as well, as the evidence suggests. Is there anything else, Bradley?
Not yet. I mean, interestingly, we've just had the community health profile, so that a lot of the health inequalities that they mentioned, yeah. So I mean, we know that with the trans plus healthcare needs, but also the waiting time that we have in this country for accessing services for trans affirming care. We know that, you know, the levels of 5+ mental health is often higher in the country, but then the access of services and care for people who are bisexual around their mental health isn't often tailored or focused that works with them or works for their needs. I don't want to get into too many of the other ones that I'm probably going to cover in a moment.
Yeah, but that's an awful, yeah, it's basically what you're saying and more. And I have been actually in compiling evidence for today's presentation, using the excellent evidence that is within the community health profiles. So apologies if you may hear or see the stuff you might have already heard or seen at the previous webinar. But I'm particularly honing on to inclusion health needs for the LGBTQ plus communities in this presentation. So hopefully there will be things that had not been covered in the previous session. So moving on, unless there is anything else in the chat, Bradley, please confirm.
Yeah, nothing else in the chat. Okay,
so if we start from homelessness then as a particular inclusion health need, we know from evidence that young gay people are at high risk of family rejection and homelessness, compounding the experiences of poor mental health. So kind of, have included this formula for actually poor mental and physical health and health inequalities on the slide. Data on statutory homelessness is not collected by sexual orientation or not collected routinely, but researchers suggest that LGBTQ plus people face higher rates of homelessness compared with heterosexual people, and that LGBTQ plus youth are at a particular risk of homelessness due to parental rejection and abuse within the family. Surveys also show that around a quarter of trans people in the UK, that is between 25–27%, have experienced homelessness at some point in their lives. And this is compared with 16% of lesbian, gay and bisexual people. Intersectional analysis from the Transactual survey found that minority ethnic groups and disabled trans groups were more likely to report experience of homelessness than non-minority ethnic and non-disabled groups. So those are quite actually astounding statistics. Another area that I wanted to kind of provide a brief overview of is domestic abuse. And the really staggering and really striking statistic here is around the most common perpetrators. The most common perpetrators of domestic abuse against LGBTQ plus victims were the people closest to their victims. A parent or guardian, followed by housemates or cohabitants, siblings, ex-partners, other older family members, and partners. Researchers nationally and internationally suggest that the higher level of domestic abuse faced by bisexual women is due to dehumanization, objectification, hypersexualization and fetishization of bisexual women. The same evidence indicates that gay and bisexual men are at higher risk of domestic abuse and partner abuse compared with heterosexual men. In 2018, evidence from the Crime Survey for England and Wales shows that 8% of gay men and 6% of bisexual men reported domestic abuse compared with 4% of heterosexual men. This was also the case for non-sexual partner abuse, which affected 5% of gay men, 5% of bisexual men and 2% of heterosexual men. And although those statistics perhaps the latter ones don't seem like it's a high percentage, but when we look at the potential of a lot of the crimes not being potentially disclosed or recorded, we're probably talking about higher numbers. This is the case for all victims of domestic abuse. We also know that 39% of lesbian and bisexual women living with a disability had experienced domestic violence from a family member, partner, or ex-partner since the age of 16. This was found as part of the evidence review within the lesbian health profile. A service provider described how lesbian and bisexual women might be forced into marriage with a man because their family members believed that by marrying and having a family, they would get over it. This practice has been also identified within some specific ethnic minority groups. The Stonewall survey reported that a fifth, which is about 19% of trans people, faced domestic abuse from a partner in the preceding year. This is compared with 11% of all LGBT respondents. Two other national surveys, which look specifically at LGBT and trans people's experiences of domestic abuse, reported a much higher rate of domestic abuse, almost 80%, although these studies had relatively small samples of respondents. And the good news in a way is that Birmingham LGBT delivers specialist LGBT plus domestic abuse services in Birmingham and has been delivering those services since 2014 and now has a specialist LGBT domestic abuse services that covers the West Midlands. Another area I'd like to just quickly run over is substance misuse. Evidence from the National Drug Treatment Monitoring System in 2021 to 2022 indicates that 2% of people who started treatment for alcohol in Birmingham identified as bisexual, 4% of women and 1% of men in treatment. This may suggest that the requirement for alcohol treatment is more pronounced in bisexual women than bisexual men in Birmingham. However, this may also be a result of an underreporting of sexual orientation in alcohol services, or bisexual men being less likely to self-identify. And this is a factor known right across the different inclusion health needs and groups. Sexualized drugs use has been highlighted as a concern for bisexual people compared with their heterosexual peers. The use of drugs such as methamphetamine and methadone as part of one's sexual activity, in particular, one of the main particular issue that has been raised as a concern for bisexual and gay men, and has also been shown to be a prominent concern for bisexual women compared with lesbian women. These are all findings from various evidence reviews as part of the bisexual health community profile. Survey findings show that trans respondents' misuse of alcohol or illicit drugs is linked to issues in relation to their gender identity, including gender dysphoria, transphobia, mental health problems, and a lack of access to gender identity services. When it comes to contact with criminal justice system, a literature review based on the US context indicates that LGBTQ+ youths are overrepresented in the juvenile justice system, comprising 13 to 15% of those in the system, compared with 5 to 7% of young people overall in the country. In the UK, however, there is no indication that young or adult gay men are overrepresented in prisons, although this may also be due to fear of disclosure about one's sexual orientation. The study LGBT+ people in prisons experiences in England and Scotland found that 7% of the prison population identify as homosexual, bisexual, other sexual orientation, and 22% of women as bisexual or other, whereas the figure is 3% in the general population for both women and men. So that study actually has found that there is an overrepresentation just of those who are reporting to have those different sexual orientations. However, The same research also found that English and Scottish prison management have good intentions when it comes to promoting equality. It also found that many members of staff have some level of awareness that about the LGBTQ plus people's needs. However, there are some significant challenges for those in custody and in prisons, because everyday practices, as the research has found, contribute in many ways to single LGBT plus individuals out as different and dehumanize them. Despite the widely accepted ideal that the punishment of deprivation of liberty should not be exacerbated by making experiences within the prison additionally punitive, many LGBT plus people in prisons do experience additional punishment simply for being homosexual, bisexual, or transgender. There were significant concerns amongst respondents about disclosing sexual orientation and gender identity. Jokes and banter were commonplace and were used to stigmatize and belittle LGBT plus people. In several cases, individuals felt powerless to challenge this discrimination because they felt that such interactions are the norm and are acceptable.
And
I think I may have missed care leavers on my slide, so sorry. Something has gone wrong. So if I just, before I move on to the criminal, onto sex workers, apologies for that, a slide seems to have escaped. I just wanted to mention something about care leavers as well, which is one of the overrepresented groups right across all of the inclusion health groups, and what it means for the LGBTQ plus young people. Reasons for entry into the care system for LGBTQ plus youth in the UK include being made homeless, family violence, family rejection, neglect and loss. A large study of the LGBTQ plus youth in care included a survey of local authorities, in-depth interviews with young people in care and qualitative interviews and focus groups with foster carers and social workers. And it reported that the primary concern for these young people in care was placement breakdown or rejection due to their sexual orientation, leading to some young people concealing their sexual identity from carers. The need for carers to be able to provide nurturing relationships for LGBTQ plus youth's resilience development was also highlighted. The report found that social workers lacked relevant knowledge about these young people's lives when helping them, for example, being aware of their specific needs, finding it difficult to talk about their sexuality, and having heteronormative assumptions. The survey of local authorities in England found that only 5% had a specific policy relating to LGBTQ plus youths, and recording of sexual identity within the care system was rare. So that's where I'm handing over to Professor Bradbury-Jones. Carrie, if you could take over now, thank you. And let me know when to change the slides.
I certainly will. Thank you very much. And thank you for giving me the opportunity to talk about this piece of work that was funded by Monica and the team at Birmingham City Council and was led by myself from University of Birmingham in partnership with a number of different organisations. But I think probably relevant to our session today, one of our partners was Birmingham LGBT, who helped us with recruitment, etc., and were a really important point of contact for us. So the study was about the analysis of the health needs of sex workers in Birmingham. And the project plan looked a little bit like this. I haven't got very much time to talk about this, perhaps about 15 minutes. So I'm going to whiz through and say that the study took place last year, and we're still just reporting on it really and getting ready to go live with the findings. There were 4 different strands to it. There was a literature review that looked at the health needs and interventions for sex workers. in England. And then there was a large national quantitative analysis of health data, recording and looking at the recordings of the profile of health amongst sex workers nationally. And then there were two qualitative strands. The first one was with interviews, one-to-one interviews with sex workers who either live and or work as sex workers in Birmingham, so local, and then an ethnography strand whereby we did some very deep ethnographic work with 3 sex workers from Birmingham. So for the purpose of this presentation, I am going to focus on particularly work package 3 and work package 4. And I've extracted from our overall kind of quite a significant amount of data. I've pulled from it some of what I think is going to be interesting and relevant to the conversation as part of this webinar. So yes, thank you. I don't want to linger on this slide too much, but I just wanted to share with you our overall framework for this study. So this was what we referred to throughout the study to keep us focused on sex work in Birmingham and nationally, looking at what are the needs, what are the health needs, and what are the psychosocial factors that impact on sex workers and actually to some extent are drivers into sex work in the first place. And when it comes to health services, how do sex workers use health services and other services, either from the actual utilisation of them or from how they intend to use them, but then ultimately do not. So hopefully, in what I'm going to talk about in the next number of slides, some of this will resonate, and my intention is that you'll see some of these elements around need and enabling factors and barriers as well coming out in what I present. So focusing, as I said, on what we learned from the study about LGBTQ plus communities, accepting the fact that this study was not solely about LGBTQ people and LGBTQ communities, but we did have quite a diverse sample. Next slide, Monica. So what the literature tells us, and some of the things that we found from when we looked at the literature review strand of this piece of work, was that the broader literature contains quite a fair amount about women as sex workers, because most sex workers are women, so that's reflected in the literature. But what that means then is that when it comes to LGBTQ plus communities, there is a bit of a gap that is evident. One of the exceptions is by Marianne Hester and colleagues, who looked at transgender sex workers, and in that particular paper they focused on gender transitioning and the financial and the psychological and physical costs of that, really. Violence, don't worry. Violence is a pervasive theme with sex work, and one that we encountered a lot in our qualitative work, and as I'm going to share with you in a little while, in our ethnographic work also. It's to some extent, and by no means rightly, is accepted as something that goes hand in hand with the job. And one study found that when it comes to LGB identifying sex workers, they were almost 2.5 times more likely to experience rape than their heterosexual kind of counterparts. Whoopsie days. And gay sex workers fear criminalisation if they report crimes more so than heterosexual sex workers. I think one of my later slides will just illustrate how difficult it is for sex workers to report anyway, because of the associations of the legal systems within which we operate. Next slide, please. So I'm going to share with you some of the findings from our work package that was concerned with interviewing sex workers. And we were fortunate enough to be able to recruit 20 participants to this phase with a lot of help from our partner organisations and also from the 2 co-researchers who worked with us on the study. And this is the profile of those 20 individuals who took part. So we had 6 bisexual men, 4 gay men, 3 bisexual women, 2 lesbian women, 2 straight women, 1 queer cis male, 1 queer non-binary who was assigned male at birth, and 1 straight man. So as you can see, really quite a diverse sample, and from whom we were able to get some really important, I think, insights into sex work broadly, but what sex work means in the context of LGBTQ plus communities. Next slide, please. So here I'm going to share some quotes with you, and I often leave quotes up for participants to read, but I hope you'll excuse me if I read aloud just so that I can speed through these rather than leaving you to kind of cogitate. So when it comes to barriers, there were very evident barriers across the piece, I would say. And these 2 quotes are illustrative of that. A lot of people have a lot of bias. A lot of people are not very accepting of sexuality that is different from the mainstream. A lot of people look at us as people with mental health issues. It's fully biased. And it's difficult when you have to face bias because of your sexual orientation. So I just try to keep to a bare minimum, and I just tick straight option. So when it comes to health forms for that particular participant, just so much easier to put straight in a tick box. I felt I needed help, and actually I got a lot of mental health I got the help of a mental health practitioner who is also a therapist. He got to know that, okay, I'm gay because it's something I wouldn't hide from anybody. I'm proud of it. So he got to know that I was gay, and at that moment I could sense that there was a little negative change in his response. So this is a sex worker who's disclosing their sexuality and then feels that the response was shifted in some way in terms of going from positive to negative. Next slide, Monica. The sexual health clinic staff need to be more open-minded about Black people and about sexual orientation. I don't think they're comfortable about me as a Black person or a Black queer sex worker. I think that they're judgmental about Blacks, and also that they have negative views about Black men. That's one small excerpt from that particular participant who was talking a lot about this kind of intersecting natures of being a sex worker, being a Black man, and being a Black queer sex worker. Now, when it comes to the ethnographic work, I wanted to share with you some of the information about Khalil, who was one of the participants. That's not Khalil's real name, it's a pseudonym. But we had 2 women who identified as heterosexual women, and then we had Khalil, who identified as a homosexual man. With a very complex life. And this is what he had to say. My professional identity is a male trans sex worker. Personal identity? I didn't choose my sexual orientation. I couldn't get on with my brothers. I didn't like sports and things that boys were doing. I hung out with the girls. The relationship I had with them was sisterly. So the kids at school labelled me as gay. I got into makeup and I had a good dress sense, so I felt a confidence that I never felt as a male. I don't feel I fit with a homosexual identity, but I do fit with a trans identity. As a sex worker, when I dress up, I have a different personality, more confident than when I'm a male. It's not the actual clothes and makeup, it's the confidence to entice a customer to want to come again. Sex work is all about attracting customers and getting them to buy. I'm good at what I do. Plus, Dressing up is useful because once you're done, you just flip it off and return to normal. Next slide, I'll pick up on some of the points that Khalil made. Talking about mistrust. I was raped by a client. The experience was bad enough on its own, but I was also very traumatized by the response I got from the police. The police are your safety net. In this line of work, you need them on your side. They are your last hope. The man was still in my flat when he called the police. The male police officers who came to take a statement just talked about how he, perpetrator, was going to be really hard to trace. And that's even though I had his details on my mobile phone. They talked about a really low percentage of rape cases that ever got to prosecution stage. They asked if I wanted everyone to know that I was gay and trans and a sex worker and that I'd been raped. I didn't know at the time that rape victims got anonymity. So I believed them and I felt completely unsupported by them and I didn't pursue it. Now I don't trust the police at all. I didn't go near any services for a very long time. So it has an impact. I stay away from health services as well as any other public services. Next slide, please. And then just illustrative of a life of secrecy for Khalil. My culture doesn't allow homosexuality, but the religion does. But the mosque doesn't teach anything about sex. I was unhappy being forced to be a boy in my family. A man who was a relative of a family friend, he invited me to his flat with him and then started sexually abusing me. I didn't understand what was happening. I knew it was wrong, but I didn't know it was abuse. When I was 12, 13 years old, I tried to commit suicide. I had to keep it all a secret because my family's culture does not allow homosexuality or sex work. I was practiced at discretion. I learned to keep secrets right from when the first man abused me as a young boy. I've hated men throughout, the characteristics of men. So just before I talk about the service perspectives, just wanted to pick up on some of Khalil's points there that he made. Now, I wasn't the person who led the ethnographic work. It was one of my colleagues, Christine. And when I was reading Khalil's account, I was really confused about what he was saying around being a homosexual, being trans, and I couldn't really quite figure out what he was trying to say. And what Christine explained to me, she got to know Khalil extremely well, was that he was very clear about his identity. He was a homosexual man and that he's not transgender. He dresses up and he does that really well, as he talks about his members of his family, his sisters, his female friends. And he performs, or yeah, he works very well at sex work and knows that he does that well. And as he illustrates there in one of the things that he says is that at the end of the day, that persona can be shed at the end of the day. And when I asked Christine, well, you know, who does he have sex with? Who are his clients? And she said they're men. And he doesn't have sex with them. They abuse him, is how he describes his own life. And as he illustrates here, he also tried to end his life very early on as a young person. So I think within Khalil's account here and the short excerpts I've shared with you, it reveals an awful lot about the complexity of his life, the secrecy, and the mistrust in services that are there to support and to help. Next slide, please. We interviewed, as part of the qualitative work, this is my penultimate slide, I think. We interviewed members of staff who support sex workers, and here are some of the perspectives from services about what they have to offer to LGBTQ plus sex workers. We provide various different support services, including sexual health services, substance support services, counselling, domestic violence services, trans inclusion, and wellbeing support services. So there are actually a lot of services out there to support sex workers who identify as LGBTQ within Birmingham. when talking about trans sex workers specifically, there's such vitriol in the media in the UK about trans people. So I couldn't blame anyone for shying away from engaging in services. And I think that's probably been illustrated in what I've already said. Next slide, please. Thank you. We've got a raft of recommendations that I wanted to share with you today, but for the sake of time, I can't, I'm afraid. But what I suppose unsurprisingly they are about is trying to make services for sex workers, broadly speaking, inclusive, non-discriminatory, accessible, where staff are trained and educated in dealing with people in a really sensitive, respectful manner, irrespective of who they are. And many of our findings are applicable to all groups of sex workers within our city. So in conclusion then, in line with previous studies, our findings show that there are multiple and intersecting barriers to accessing health services faced by sex workers, broadly speaking, all sex workers. And the barriers are, that's supposed to be not and, the barriers are multiplied by the intersecting identities of LGBTQ plus sex workers, without a doubt. And this is in italics just because it's taken from our report, and it says that staff training is required that focuses on the intersectionalities of marginalisation and discrimination which sex workers face, both due to their work, social assumptions about sex work, a highly stigmatised line of work, and also due to other intersecting personal characteristics, including sexuality and gender. So I think that leads me back to you now, Monica, and I'm happy to have any comments put in the chat. Would really very much welcome that.
Thank you very much, Carrie. Oh, co-leavers have appeared here, so the slide hasn't quite disappeared completely. But I just wanted to put this slide and this question and leave all of the participants of the webinar with this question. Carrie has underlined and I have mentioned throughout the presentation the importance of intersectionality, particularly for LGBTQ plus communities when it comes to various health and health inclusion needs that they are experiencing. And it's important to keep on asking ourselves this question when we are designing services, policies, and when we're trying to respond to the needs, health needs and well-being needs of the LGBTQ plus community. So I'm just going to leave you with that question as part of your reflection, hopefully after the webinar. Hopefully you found this information really useful. But just very briefly, maybe over the next 5 minutes, it would be useful to have a little bit of a discussion or commentary around how things are improving and whether they actually are improving. We've got a number of policies and frameworks globally, nationally, and also lots of local good practice and various programs developing that are specifically looking at LGBTQ plus health. But are things improving, and what it is that you can perhaps share with us that you're involved in that is hopefully going to make a difference or is making a difference. So I'll open the floor to a bit of discussion. So rather than chats, if you've got something to share, please put your hand up and introduce yourself and or not, and share your thoughts. And Bradley, if you can help me with
Yes, yeah, of course.
Navigating the chat in the hands.
Will do. And just why people might be thinking around what has improved or what isn't improving, or what they think of some of the stuff that's been shared today.
And rather than overthinking, is actually what do we feel? What our experiences are as either service providers or recipients or policy makers, whatever that role might be.
I mean, I have one, Monica, if you don't mind. Just to be a bit of a devil's advocate. With the financial situation of like local authorities, of the NHS, of just generally of the public sector, who lead on a lot of this LGBTQ plus improvement in health and well-being, is it something that we need to be worried about not being on the agenda because it's seen as a nice to have rather than a need to have?
Well, I hope you're not asking me to answer the question, Bradley, because I you know what my answer would be in terms of what it should be. I think if we're not tackling any of the inclusion health groups, inequalities they experience and poor health outcomes, then we're never going to tackle health inequalities, full stop. And that includes you know, as the evidence has been presented, these significant, truly significant health inequalities that the LGBTQ plus community are experiencing. So my view is, you know, we can't afford to not to take notice of those facts and that evidence and those inequalities for LGBTQ plus community, as well as other inclusion health groups. However, I completely understand the concern, and I share it as well. So that's not the answer to the question, but I think all we can do, and that's what actually the role of my team within public health, and also the fantastic academics that we have working with us, to including Carrie and her team, to shine the light, to bring the evidence to the fore, and continually advocate for the needs of the inclusion health groups.
Thank you. And still haven't had a question in yet, so if anybody else got a question, if you want to put your hand up, put it into the chat.
Question or a point to raise or a comment to make, whatever thoughts and reflections you might have, or something, actually some good practice to share as well, because we know about some of the really interesting programs and organizations operating locally and nationally that are really putting the LGBTQ plus health at their heart. So it'd be useful to hear some positive stories as well.
Brilliant. We have a positive story in the chat. So from Cara, hopefully I pronounced your name right. My cousin is transgender and they've received loads of support from school and health services, which he says has been really good for him.
That's fantastic. Yeah, that's great. And perhaps that is it within the school, or is it? Sorry, because I can't see the chat, Bradley. Was it within the school?
From school and health services.
Okay, so from school and health services, so perhaps that could be shared across the education sector as well as the healthcare sector, in terms of how that works. If this is the experiences that young people are having, it's brilliant.
Yeah, I mean, definitely we need to platform and share best practice as much as possible, don't we? Because there is a lot to change and to improve, and we do that from learning from best practice rather than just focusing on what isn't working all the time.
Absolutely. So what we have focused on is highlighting the needs, but actually what we need to do is we need to follow on webinar on actually what the best practice looks like and what it means when it makes a difference on the ground to those communities and to the young people. that would be really great. So here is a suggestion. And with that thought, and please carry on sharing that information. I know you might be also attending other webinars, but share with the organisers, and as part of your evaluation as well, it would be wonderful to highlight the areas of best practice when it comes to tackling health inequalities affecting LGBTQ+ communities. So I'm just bringing this to a close now, conscious of time, and trying to give you about 5 minutes for a short break before the next webinar starts. Just a reminder, we've got evaluation forms. It'll be really grateful to receive your feedback. And also there's some other webinars left this week, and I'll leave for the team of organisers, Bradley, to include more information in the chat.
Yeah.